So with that note, of course, with a lot of people to make this show here possible, a lot of help from many our industry partners and audiovisual and with the Gaffney events to make this possible, and of course with the Broadmed AV. Let's see how everybody performs, and I'll go through my same top 10 trials of coronary intervention, which have changed our clinical interventional practice in 2025 onwards. So as you see, I put it 624. So there will be no slide which I presented last year. There may be one or two just for a reference, but not for the topic point of view. All will be the newer data since our June of 2024. I start this I would call the Anders Grundtvig is the father of, I'll tell you because my statement will follow a little later, father of old angioplasty era. So that's how the field started, and that's where we are. Dream of the catheter-based percutaneous treatment of vascular disease in alert and awake patients. Remember, his was see one, do one, teach one, and that is part of the life. That's what it started. And a lot of stalwarts in interventional cardiology has propagated that further, and just like us also for monthly webcast. And what I added is the safety has to be safe, appropriate, and of course, ambulatory. We know 60+% cases are discharged same day. So this will be the relevant one. The first one is our mechanical circulatory support in cardiogenic shock. Lot of data at present. The three of them you see here, balloon pump, Impella, or CardioHealth, which is ECMO, is part of most of the cath labs should have it. Even by relatively small hospital back in Jaipur, mine ESCC, we got ECMO because any catastrophe happens in the cath lab. Data of the cardiogenic shock are different, but one device which will take you out from the cath lab catastrophe is ECMO. So the data of the ECLS shock of the 420 patients showed no benefit. You see up to 1 year. So overall, the trial point of view, patient randomized to ECMO versus standard therapy, no difference in any outcome in cardiogenic shock. There was a lot of criticism, maybe the ECMO was done too late and so. What really made is our Impella, which is the microaxial flow pump, which is done in the Denmark, then the Germany, took although 10 years, but 360 patients. And first time, we were able to get decrease in mortality of the cardiogenic shock from 59% to 45%. So 13% reduction, despite having higher vascular complication, although there's no effect on the renal. Now, you can imagine if the vascular complications are lower, probably difference would have been even higher in terms of the lowering the mortality. This was just a 6-month trial of 180 days, but just to say that now the field is progressing. Almost every device company has the MCS, and we are going to the smaller size with a 9 French, 9.5 French, will be available before the year end. Then the balloon pump, another trial, although this was more in the cardiogenic shock, called Alt Shock 2. These are the non-ischemic cardiogenic shock, and showed basically again about 100 patients, no benefit of balloon pump. So balloon pump continues to get a little negative, rather more vascular and bleeding complication, but no true benefit. But despite all the data, this is the national trend. ECMO numbers are going up. Balloon pump is actually more of a stable national trend. Impella is tremendously going up. The cost I have put in the red letters that clearly the ECMO is very expensive. Of course, the balloon pump lower and Impella in the middle. So that basically is for but cardiogenic shock, despite the growth of these, the data we have is only for Impella, others not necessarily for cardiogenic shock. And that actually has gone to the ACS latest guidelines, that Impella 2A and patients, but particularly balloon pump or ECMO for cardiogenic shock still remain class 3 because no benefit of the various trials which we have seen. The second is the procedural versus spontaneous MI, differential mortality, led by Dr. Roxana Maran from our interventional database. The question always used to be, remember many of the trials of our interventional cardiology against medical therapy and PCI, what shown that PCI decreased the spontaneous MI, although it increased the procedural MI. So question is there a differential, the prediction of the subsequent outcome based on whether you are procedural or the spontaneous MI. So this is from our database of large number of patients. We have you see patient who is stable CAD, those who had no MI, procedural MI, or then followed that for the spontaneous MI. And what did we find? that procedural MI, which you define at 1 to 5, 5 to 35, or more than 35, occurs in about 10% of cases, real more than 35 and less than 1%. But very important on the right side, no MI and procedural MI has kind of same outcome at 1 year in terms of mortality. But if you have spontaneous MI, it's triple. First time methodically shown in the literature, and this actually shown here in terms of odd ratio, any increase in the spontaneous MI, any degree associated with mortality, but for the procedural MI, only the large MI. So basically where you have, like dissected the big vessel, big side branch and so. So the question comes, why that's a difference? And I think the difference basically is the procedural MI is happening in the hospital, and you can treat it. Second, that it may be diffuse atherosclerosis, and some of them may be type 2 MI. We know type 2 MI because of tachycardia, and so is less harmful than the type 1 MI. The third is drug-coated balloon. Another device which every company has to have it. With the whole field now actually USA, in the coronary point of view, just started from last year. The whole concept is that drug, rather than leaving the stent, all the drugs which have been used for the DES can be used for drug-coated balloon. Paclitaxel has the historical largest data, then the sirolimus and other drugs are coming also, and can be used for both ISR as well as for the native vessel. And advantage is, because you have no stent thrombosis, no side branch closure, and maybe abbreviates the DAPT duration. And of course, maybe less inflammation. So see whether the trials prove that. Agent IDE, which was led to the approval of this agent drug-coated balloon last year, showed in ISR patient with a 2-to-1 randomization, significant reduction in TLR and target vessel MI using the drug-coated balloon of the agent type, and this is led to the approval, and individual endpoints are here. And as I said, there's no stent thrombosis because there's no stent. And that's proven by the agent IDE. Now, agent device. There are, at present, we are part of the 2 randomized trials for the drug-coated balloon in the ISR, as well as the second point is ISR understood, very good. But what about the native vessel? That field is also exploding because some data in the past have shown that for a small vessel, drug-coated balloon work very well. So this is a trial from China, RAC cage-free 1, where they use a paclitaxel-coated balloon and Firebird sirolimus-eluting DES. Now, I just want to say, once you're going to the native vessel, the concept has to be that you are preparing the lesion. If lesion prepared nicely, then question comes, putting a drug-coated balloon is equal to DES. If you could not open the lesion well, there is a dissection, then you have to do a DES. There's no question. So therefore, all the trials have, you prepare the lesion, looks good, then you randomize to DCB or DES. So see what happened. These are the non-complex lesions, and overall showed that no good. In native vessel, although some data in the past were contrary, but here, one of the largest studies shown of 2,200 patients, that overall device and patient-oriented outcomes were much higher in the DCB group, which is the blue bar compared to red bar, and more importantly is that if you go with the vessel size, the benefit is, or not benefit, or they were equal in the small vessel, but in the large vessel, outcome was almost 3 times. So clearly the large vessel, as far as we know, with this one of the data showed that the DCB is not good, and therefore I put it together that patient comes in, native vessel or your ISR, once the DCB strategy, or people are calling now as the stentless PCI, the stentless PCI, no, or metal-free PCI. So various names are being done for that. So lesion preparation, by whatever technique you use, all allowed, including atherectomy. And if you have good acceptable angiographic results, then you go with DCB. If you're not acceptable angiographic result, suboptimal, then you DES. Very simple. Only point is, it is discouraged that after DCB, you don't do the imaging because you may shear off some of the drug, plus minus, some people say yes, some not, but we don't do it. So that is what all the trials require, that after the DCB, you do not do the imaging, and of course, DES, we always do the imaging. And so just to sum up, where the DCB has a role in this time, DCB in ISR, small vessels, side branch, lot of trial data have shown it works well, but particularly small to medium size, and particularly high bleeding risk, where you need to worry about the DAPT interruption. Then the imaging trial, last 8+ years of various the devices, imaging devices, including the NIRS, OCT, IVUS, in addition to our angiogram, as you see, numerous trials, over like 30 plus, in various ways. Because we said, okay, we did a good PCI, but patient comes back. Trouble happens. How can we optimize our results of PCI? And that's many trials have been. I just want to show one trial of the OCUPy patients with the complex lesions, long lesion, bifurcation, ISR, graft, and they have a very good criteria, OCT guided versus angio guided, done in South Korea. That OCT criteria, not leaving the dissection alone, your stent is fully optimized, and so on and so forth. And that led to, again, duplication of what we learned earlier, that OCT guided blue bar compared to red bar, better outcome of these patients. And then what about the imaging in the DCB cases? So there was an ultimate 3 trial from China, also showed the same, that by using the imaging, but it was done more, not in the end, before to lesion preparation, that you got a better lumen post-procedure, less late lumen less, and overall outcomes were good. So imaging with the DCB also, not necessarily in the end, but in the middle to use it. Now, Greg Stone put this meta-analysis of all the trials, and just to say on the right side, if you combine at that time and was done last year, the imaging benefits in every aspect of interventional cardiology, with odd ratio decreasing anywhere from 20 to 60%. But most important, stent thrombosis is half of the imaging trials. So this actually, in the United States, we are about 1/3 only, because this is the data of the last quarter of the ACC NCDR, and 75% versus 25%. I believe of the 100% benefit of imaging, 80% comes with the post-procedure, where you have optimized your results. That led to the guidelines we all know, both European guidelines for the coronary syndrome with the complex cases, now acute coronary syndrome, again for complex cases becoming a type 1 indication. That number, which is 1/3 in the USA, might go to 50 or 60%. Because there's strong demand, and this is the field evolving, so Anu decided, so we actually, as you remember, that we have a second Tuesday of the month do structural, third we do a complex coronary, fourth we do a endovascular, so first week remain vacant from CCC live point of view. So we added now two every other month webcast. One is for the imaging, has been a big hit. They did 2 cases so far. The next one is on August, done on I always want to have a particular day, which is the first Friday. Next one will be in August 1st. And this actually has been a big hit with our associate, and Kiski is a great guy for that part. And then also, we, from our, again, database, 1,800 plus patient, all angiogram was, because she always good into making the app, prediction of the risk score. So bifurcate risk score, bifurcate app, we have app 1, app 2, and now incorporate that, in terms of the risk factor, the patients who come back after the bifurcation PCI, with the lesion risk factors and the clinical risk factors, come up with total 36, and you have gradient of low risk, intermediate risk, and high risk in terms of event rate of the MACE, MI, and TVR in 1,800 plus patients. So very important, I'm sure it will translate into the app very soon by Anu. Then the plaque modification. This year, numerous trials were done for the plaque modification. The one of first was that whether imaging helps in severely calcific lesions. OCT, IVUS, or angio, 130 plus patients, and basically showed MSA, malopposition, late loss, and restenosis. You can see there is a little trend, although no p-value except in the late loss, lower late loss in the OCT compared, and the IVUS compared to the angio, but everywhere else kind of a trend, but no definite because a small number of cases. Just to say that in calcific lesions also, the imaging help both of IVUS or OCT. Then the OCT in Calypso trial, it was imaging study. The clinical follow-up will come later to show that even calcific lesion, OCT gave you better lumen, MSA of 6.9 versus 5.3, and associated with a less malopposition. Will it translate into a better outcome? We need to see from the investigator when they present their follow-up data. Another trial which looked into, because we had a lot of atherectomy devices, IVL, laser, rota, and of course the orbital atherectomy. So question is, if you compare 3 of them, ROTA, IVL, and ELCA. What it showed, that in terms of angiographic success is identical. The severe procedural complications are the lowest with IVL. We learned that, right? Almost no perforation with IVL. And lastly, when you compare the devices, laser lost it. Because the new technique, RA was better than the laser, and same way, RA and IVL were equal. And in the calcium fracture point of view, we have more fracture, particularly single fracture with IVL. So just to say, for calcific lesion, ELCA, laser did not do well. So it was inferior compared to other two techniques. Then, what if we do rotational atherectomy for ISR compared to what we did drug-coated balloon? This is actually the start of the roster trial, which we did, then artist trial in the past, and showed no good. Routine rotational atherectomy for ISR actually had a higher event rate, numerically higher event rate, shown in the height of the blue bar compared to the red bar. So it's not indicated. Then the major trial, which all we were waiting for, Eclipse trial by Ajay Karteni, presented last year in TCT, and was about 1,900 patients. OA strategy compared to balloon angioplasty strategy, and the outcome at 1 year, and the imaging guided outcome also, and basically showed that overall minimum stent area was slightly better, trend towards with the orbital atherectomy, but outcome, as you see on the right, identical, 11.5 versus 10. So orbital atherectomy did not improve the clinical outcome of these patients at 12 months. Now, there were some procedural complications. Slow flow, actually, I was shocked. We always taught people that orbital atherectomy does not have slow flow compared to rotational atherectomy, but they had higher here, and there was a non-significant trend towards a little higher perforation, 1.8 versus 1. These complex lesions do have 2 to 3% perforation, even our other trials of rotational atherectomy, Rotaxis, and prepared calcium. What we learned also again in this trial, the orbital atherectomy, the OCT which was done with orbital, 2/3 of cases, the outcome was much better once you use incorporated imaging guiding. So clearly, more and more data are coming. Even in the calcific lesion, you need to improve the outcome. Irrespective of the device, imaging helps. And these are the clinical endpoints, so that's where we are. Then the issue always happens. The old patient, 75, 80, 90 years old, come with STEMI. Data have shown PCI is better. But what if it's a non-STEMI? So this is done from UK, the senior RITA trial, basically 75 plus, randomized, 1,500 patients to invasive arm versus conservative arm, and followed for 5 years. Now look at the right side. Patient in the invasive group, or 90+% went to the cath lab. But how many had a PCI? Only half. So just to tell you, the non-STEMI is a diffuse disease for whatever region. Investigators have decided not to do PCI, just manage them medically. And in the conservative group, about 6% required. Just to say, with taking that strategy, what they found, no difference at 5 years of death MI or any individual endpoints, except the revascularization, of course, was higher in the conservative strategy, which is expected, but without any hard endpoint. So just to say, old non-STEMI patient, it's okay to wait, manage them medically, breakthrough, then they go to the cath lab. Then clear synergy, which is OSIS 9 trial of Colchicine, and then there is a recent about the plaque the measurement. As you know, the colchicine basically on the microtubule and many anti-inflammatory effects, and 2 major trials of the Colcott in acute MI and Lodoco in stable CAD, and then of course showing that meta-analysis that colchicine is a great agent. Over the years, we learned quite a bit, and then showed that every aspect, it decreased the event, except the mortality, but everything else was decreased by using colchicine compared to non-colchicine group, and made the class 2A indication. So everything good. We started using colchicine. I actually tell you, before even this, we had a discussion. I'm sure many of you might be happy. I use colchicine to a very dismal. And they know this is the trial which was done, OSIS way before. After the initial enthusiasm, personally, I did not find any difference with colchicine in the practice. But anyway, this was the trial, the major trial, which is 2x2 factorial design, colchicine versus no colchicine, spironolactone versus no spironolactone. Our interest was colchicine group. What colchicine did, supposed to do, that decreased the CRP, as you can see, compared to placebo. That's good. We wanted that, and that has been shown earlier. But outcome-wise, 5 years, no difference. Now, these were the patient, acute MI, Drug was started within 1 to 2 days, and after acute MI PCI, colchicine was added on to the existing therapy, and outcomes were no different as you see at follow-up. Any individual outcome, rather there may be some of them had little noise in terms of pericarditis and so forth. And the question is whether it's a dose maybe increase, that all remain, but GI side effect with the diarrhea, and so much higher with the colchicine versus no colchicine. They say why that happened. Of the various actions of the colchicine, it turns out to be, some investigators suggested that when it blocks the VEGF, that probably translated into a bad outcome in this post-MI patient where you started right away. So you want some proliferation initially, and that was inhibited by colchicine. But the field is not done yet. Now, based on the previous trial, whether it still remained 2B or 2A indication, we need to see. What about the plaque progression? We know that CRP level, this is a small study about 80, 90 patients, Ekstrom, just presented in ACC, no paper yet. We showed that, yes, colchicine decreased the atheroma volume. And we also know every time atheroma volume decreased, translate into a better outcome. So this was more of a CT study, CT angio study, and showed that, yes, colchicine decreased the atheroma volume and the calcific plaques. Then FFR trial. FFR is the part of our armamentarium. We actually have the FAME trial, which you remember a few years ago we presented 1 year where FFR-guided PCI for the multivessel compared to cabbage was inferior. And then we have 3-year data, which I presented last year, and now the 5-year data. So 3-year, this is the slide I presented last year, that there was a trend of the death, MI, and stroke is still in favor of the cabbage versus PCI, and individual endpoints are here at 3 years. Multivessel, 3-vessel disease, not left main, FFR-guided PCI versus cabbage. Now we go to the 5 years. And very happy, and I know there are a lot of interventionalists in this room, probably very few surgeons or maybe none, that at 5 years we caught up. No difference. In terms of the individual endpoints, right here. So of course, no difference in the sense we major endpoints. Of course, we know the repeat revascularization will always be higher, and there was slightly higher MI, but key is the major endpoint were not different so what it means, that if you know that patient's lifespan is short, I think even a complex cases doing a PCI will be reasonable to do. And more so, simple lesion did better with the PCI compared to more complex lesion. Now then, in terms of the syntax score of 22 which have been shown, first is the syntax trial. Remember our outcome 12 years, so just to also emphasize that how our interventional cardiology has improved the patient's outcome. Look at the syntax trial in 2014-15, 10 years ago, outcomes were 14.6 and 9.2 in terms of mortality. Now in the FAME trial was 7. And the death, stroke, MI, all decreased. So this is the power of overall management. I would not attribute only to the interventional cardiology, but better management of the patient in terms of the lipids and others and antiplatelet therapy. This is another paper showing that maybe 22 cutoff, which was original, maybe in this day and age for the PCI, probably should be 24 and associated with a better outcome. Then FLOWER MI, which is the trial which was presented before, FFR-guided versus angio-guided patients in STEMI patient. Now at 3-year follow-up, basically show no difference. So FFR in acute MI setting, plus minus, usually no benefit with the 2 trials, and the individual endpoints are shown here. So it may not be indicated in acute MI setting, while in chronic, yes. Then a question always comes. You're done 12, 18 months of your antiplatelet therapy, now do what? Continue aspirin, continue clopidogrel, or continue both? So we may not have answer for both, but should it be aspirin or clopidogrel? We have 2 major trials, Smart Choice 3, done in South Korea, that after patients have completed, those who are high risk, 5,500 patient, high risk in terms of previous MI, diabetes or complex PCI. So these are the high risk patients, not a simple. They randomize after their 12 to 18 months, whether to clopidogrel monotherapy or aspirin monotherapy. So this is where we needed one answer, and basically showed that clopidogrel monotherapy was superior compared to aspirin monotherapy. So that's one answer. Second was bleeding. Actually bleeding, some people say maybe more, no difference in bleeding, so that's a good news. And more importantly, individual data when the patients who are more complex, diabetic, they derive the better benefit of the clopidogrel compared to aspirin. And GI. GI side effects were much lower, so anytime patient have GI side effect, clopidogrel will be a better agent compared to aspirin. So this is basically the conclusion of the trial. Then we have, which I presented about 3 years ago, host exam, which have now the latest paper in the JAMA Cardiology in terms of the thrombotic and the patients who are high risk for bleeding, as well as in those who are complex cases. It showed that even in those patients that giving clopidogrel or similar kind of design that associated with lower event rate and lower bleeding, and also lower thrombotic events in these patients in the complex cases. So overall seems to be clopidogrel is a winner as a single therapy after you have completed the duration of your antiplatelet therapy, whether it's a 6 months, 12 months, or 18 months. I would say that 2025 and 24 end was a banner year for us because we have 2 guidelines, which is rarely happens. That we have later European as well as American guidelines came. One for chronic coronary syndrome, stable angina. The term has changed. We don't call it stable ischemic heart disease. Now we call the chronic coronary syndrome and acute coronary syndrome, we know. So both guidelines actually complementary on various aspects of teaching us quite a bit in terms of which patient is a high risk, clear-cut definitions of the high risk, and incorporation of the physiology, making a class 1 indication, which we know. Very interesting, the QFR, which is the non-invasive, has made to the class 1 indication because enough data have come that non-invasive, just by your by angiogram or CT, without putting an additional wire, the prediction of the event rate are quite high. And then testing. And I would say in nutshell, in the testing, the CCTA, which I was a believer for last 30 years as a screening test. Now actually, as you see in the most of the disease process, even prediction as early stage is the best one. Not the calcium score only, but CCTA for angiography in terms of the working for these patients. And of course, the LDL now has gone down to 55. I'm sure soon it will be 10. Because there are a few people in this, I know a few of my referring friends here, they want to keep the LDL 10 or 20. And Jagat Narula and Brownwald, they all apparently has been in the media that who has the lowest LDL, whether it's a 20, I'm sure next we will have some report that both have LDL of 2. But just to say, the rest they continued imaging I mentioned and the heart team discussion and so and so forth in this our European society. And another good thing happened based on the available data now, some from the Excel, that simple left main, particularly your syntax score of 22 or below, is okay. It's a class 1 indication for PCI. It's no longer 2A or 2B. It's a class 1. Once you go to more complex left main and high syntax score, of course, it remains the 3 indication patient should go for surgery. And DES is recommended, and that's what I'm biggest concern is that the DCB trials of interventional cardiology. All the DCB trials, they're against the balloon angioplasty. They're not against the latest one. RIPS and earlier trials were there. But latest trials, they're all going with the DCB versus balloon angioplasty. But your class 1 indication is put another DES, where DES ISR happens. The another important is the non-patients who have angiographically normal coronaries but continues to have chest pain. So ANOCA and INOCA, which is invasive coronary functional testing, they have the whole plan, how these people should be tested. Many centers have developed the protocol, and like us, Sinai also with the Joe Sweeney, we started every other month imaging, and every other month this microvascular coronary functional testing live. We started, they have done one already with a great, so just to continue whatever is happening in the latest literature, try to show and educate our audience, and I'll tell you the numbers. The other point in terms of the abbreviation of the DAPT duration, bringing down to take the aspirin out about 3 months, and adherence therapy, very important is the rehabilitation and particularly cardiac rehab. And every aspect of the cardiac rehab have shown to improve the overall outcome. It's not only rehab that you do exercise. There's a diet issue, there's cholesterol, smoking, every factor, and so. So ACC complemented, I think by and large, there are very few new things came up, although there is a paper has been written by Dr. Fuster and his associate that what were the major for the ACS guidelines, but I think more what we understood, Patients, high risk ACS features, go to the cath lab. Intermediate, you decide. Low risk, you get a stress test and then decide what to be done. So that strategy, we have been doing it, and it continues to be. And of course, in some complex cases, even cabbage should be done. And we know STEMI multivessel, full revascularization rather than culprit, and in cardiogenic shock, only culprit revascularization, not the full. Then the LDL cholesterol, they kept same 55, and so this is very important, which is not that clear from the European guidelines yet, but clearly from the US guidelines, that single antiplatelet therapy after 3 months of ticagrelor monotherapy is class 1 indication. And guess what? That is because of course, many, but big credit goes to Roxana Maran from the Twilight trial made to the guideline with a class 1 indication. So safe to stop after 3 months aspirin, and associated with this equal outcome and less bleeding has been shown. And the whole idea is, we learned that stents are very good. You can decrease the depth to the monotherapy. So just want to emphasize once again every aspect of the cardiac rehabilitation, which both of these studies, the guidelines have emphasized that not only what we do, now we have to prevent the event. How can you prevent the event is all the factors which have been laid out in this nice pictorial, and this is being done at most of the centers. So with that note, these are our top 10, and I always say, sometimes I might have gone a little fast, but I had to put it together with a central illustration, which Dr. Fuster started when he became the Jack editor, that put all this. So there may be a manuscript of 30 pages. So he started that you have to put in one page, in one figure, what your paper is all about. So that's why let's put it together, central illustration, what we learned. ECMO and balloon pump in cardiogenic shock, ROTA in ISR, drug-coated balloon large vessel, Colchicine acute MI, 2 thumbs down. Basically no good. FFR-guided PCI in multi-vessel STEMI, invasive strategy in old non-STEMI, and orbital and laser in calcific lesions, 1 thumb down. FFR-guided PCI versus cabbage at 5 years, increased mortality with the spontaneous versus procedural MI and bifurcated risk score, 1 thumb up. Impala in cardiogenic shock, IVL and ROTA in calcific lesions, and clopidogrel over aspirin for long-term post-PCI, 2 thumbs up. And the DCB in ISR, imaging, OCT or IVUS, looks like data are equal, various kinds of plaque modification, guided PCI, even in the calcific lesion, and the latest guidelines of the ESC with the CCS and 225 ACC with the ACS, PCI guidelines at 3 thumbs up to improve our overall interventional and outcomes and survival. So just to say, we actually, New York State, it's a very interesting, they give you a comparative report. Last one is 2019 pre-COVID. They have not done it since then. We have done quite well in terms of volume and the safety. Double star means your mortality is low, risk-adjusted mortality at 30 days is lower than the statewide average. And CCC webcast, I already mentioned, very successful, which 20,000+ hits per month. No other activity in the world has that much audience, and now with the imaging microvasculature, they may even go further. We have good 2 biggest partners for that, USA and India. India is very, very popular activity, of course, many other countries with the 170+. And the educational point of view, the Anu is doing a great job developing app for any disease process to move this field forward and make life of our intervention a little easier. Not every time go to the books, and so that everything can be done with the app. With that note, I'll stop here, and thank you very much. So now, of course, question will maybe later if necessary, but I want to continue and want to start just introduce a very unique the event which will continue as a part of our the CCC the symposium is my father, Anandilal Sharma, if they can show the slide, that he died 2 years ago after the COVID event, been very close to me, and I'm starting, we actually have my endowed professorship, as well as we used to have our the endowed, our monthly visiting professor. If they can go to the last slide, of course, our parents, both parents are very close, my mother and father, but my father was especially, guided me in my early days. to help me, my career, showing the numbers with my other, the colleagues. Competition-wise, I topped those who know that Rajasthan University, not only my college from Jaipur, that's where the hospital. So I felt that it's a great tribute will be his name, that we make a Anandilal Sharma Memorial Keynote Lecture. This is the first time we have done it. And when this was being planned, and we were asking Roxanne Meran, and then we came up that only one person who can receive this as a first one is Dr. Martin Leon.